Hi, I'm Natalie Gedeker, and I'm back here with Dr. Nancy Kuntz, who's a neuromuscular, a pediatric neurologist at Lurie Children's in Chicago. We're going to be talking a little bit today about some obstacles to diagnosis in Duchenne muscular dystrophy. And Dr. Kuntz, I'm wondering if you can just kind of start speaking to what you think some of the main obstacles are to diagnosing these young boys.
Yeah, certainly. One of the things that's most important to recognize is that there is a high rate of spontaneous mutation with this very complex dystrophin gene. And about 30% of the boys that all of us see who have Duchenne muscular dystrophy do not have a family history of this. I'm beginning to think it's probably a combination of new mutations as well as smaller family sizes. My mentor gave me slides of 5 boys, each 1 year apart in a family who all had Duchenne muscular dystrophy, where you could see the natural history just through the different postures of the boys over time. But most families these days don't have 5 boys 1 year apart. So those combinations make it harder to predict which families and which boys might have Duchenne muscular dystrophy. And then you add to it the fact that the clinical signs are very subtle. Individuals who've monitored Duchenne for many, many years have noted a very tiny bit of neck flexor weakness in newborns who have Duchenne muscular dystrophy, but it's a subtle finding. And a little bit of head lag can be ascribed to many things, a little bit of stress at birth or whatever. But healthy term newborns usually will try to crane their necks forward if they are gently slid to the edge of a bed or examining table. But boys with Duchenne, in my experience, don't do a good job of keeping their heads even with the table or craning them forward. So that's about the only clinical sign that one could put into perspective for very, very young children. So those are clear and obvious obstacles to a clinical diagnosis. But in addition, I think that there are many families that have a lot of practical and socioeconomic issues that attract their attention. Certainly as a working mother myself, I know how hard it is to both take excellent care of yourself, your children, and earn a living. And many of our children in the United States have working parents, 1 or 2 in the home, who have a lot on their plate. And so a little bit of symptoms, something that isn't preventing the child from eating and growing and making some developmental gains, a lot of times becomes a little bit less critical to put time and attention toward than some of the other practical issues of supporting the entire family. The other thing that really does help, though, is a really solid primary care provider and a real good medical home. And I've found myself that these are sometimes hard to find and then sustain. Even if you have a great relationship with a primary provider, sometimes the pace of medical care and well child care speeds up, and there isn't a lot of time for them to spend with young children. One of the mantras that the CDC recommended at one point to primary care providers was watch them walk. If you have a 15 to 30 minute well child check with a lot of things to accomplish in terms of the general examination and anticipatory guidance and prevention, all important, as well as parent education, sometimes the primary care provider does that and rushes off to the next appointment, while then the child gets down off the examining table or their parent's lap and waddles down the hallway, with that waddling gait not meaning anything to the mother, but it probably would to the primary care provider, but there was no time for them to observe that. One of the other things that sometimes diverts early diagnosis is the fraction of children with dystrophinopathy who have more significant speech, social, or language delays. And then those are attended to with a lot of attention and diagnosis, MRIs, EEGs, developmental pediatrics, consultations and things of that nature, psychology sessions, autism scales and things of that nature can take a lot of time and attention, and they're very important to follow up on those lead symptoms. But many times it delays obtaining a CK or other more direct testing that would identify the cause of the developmental problem as a dystrophin mutation.
Thank you, Dr. Kuntz. I think that was a really great summary about some of the obstacles that we see in getting these boys a diagnosis with Duchenne muscular dystrophy. Our clinic, we also see a lot of boys where there is something that ends up being flagged. It's just not quite sent to the right person. So in addition to what you mentioned related to this speech delay and the autism, where the children will see a neurodevelopmental specialist, we also see children first referred to an orthopedic doctor, for example, because of the toe walking that they can sometimes experience. And very often we'll see young children first referred to a physical therapist as well, who's sort of trying to help build up their strength and work on some stretching exercises that just never quite become effective enough. Oftentimes we do encounter very good physical therapists in the community who then give a push back to the primary care doctor to get the boys into a neurologist, which is always what we hope. So it does sometimes come around. But anyway, I think that was a great summary. So thank you.